Thank you very much. Glycocalica, what a beautiful word. Maybe my next daughter, Glycocalica. Okay. So the topic of my presentation now is the intraoperative infusion of fluids, and the challenge for me is to give answers to the question which fluid and how much should be infused. And I will also try to clarify the impact of the glycocalyx on infusion therapy. In order to answer these very interesting questions, I want to speak firstly about the basic physiological principles concerning perioperative fluid balance, and thereafter about the basic characteristics of infusion solutions. And the real challenge is to unify this to a simple concept concerning perioperative infusion therapy. And my personal target is to create this concept as simple as a cooking recipe. So addressing perioperative fluid balance in my presentation today, I will cross-reference between the existing myths and the somehow disappointing facts concerning perioperative fluid balances. It is easy to conceive that a positive fluid balance might have negative impact on outcome regarding major surgery, which is the focus of my lecture today. Causes are the increased diffusion distances due to tissue edema, which can lead to poor wound healing. The question is this a myth or a fact? So Brandstrup et al. Stated in their review that a restricted intravenous fluid therapy improves outcome in patients undergoing major gastrointestinal surgical procedures. This statement is mainly based on 3 studies. Lobo et al. Showed that a positive salt and water balance delays the return of gastrointestinal function and prolongs hospital stay. Brandstrup found that a restricted perioperative intravenous fluid therapy aiming to maintain body weight reduces cardiopulmonary complications and increases tissue healing. And finally, Misanevich could demonstrate that a restricted fluid management seemed to be advantageous because it reduced postoperative morbidity and shortened hospital stay. Rabiri, in their review, also came to the conclusion that a restricted fluid amount can reduce perioperative mortality. However, in an excellent review on perioperative fluid balances, which was based on a large mainline inquiry from 1966 until December 2005, Holte and Kellett had to admit that the available randomized studies do not allow evidence-based recommendations on the optimal amount of fluid to be administered in elective surgical procedures. A further review came to the same conclusion. Evidence-based guidelines for optimal procedure-specific perioperative volume regimen cannot be formulated. So why is this the case? Since so many studies showed so clearly that restrictive regimens are superior to standard regimens. The reasons here. You can see the different amounts of fluids which were applied intraoperatively and postoperatively in the different studies. And this was absolutely inconsistent. Especially if we consider the postoperative period here, we have to be aware that the restrictive regimen of one author was absolutely comparable with the standard regime or even liberal regime of others. As there is no consistent terminology, what really is restrictive, what standard or liberal, the respective results of the various studies are almost impossible to compare, and this leads to a disappointing conclusion. There is no evidence concerning perioperative fluid balances. As a result, my personal conclusion concerning the all-in-all balance is that a positive fluid balance is not inevitably negative for the patient's outcome, and fluid restriction is not necessarily good for the patients, and this should be valid also vice versa. But if you think that this blank conclusion now is the end of my presentation, you are wrong. In the following, I will try to answer the question, how much of which fluid should be infused to maintain normal volemia in the perioperative period. By measuring double-label measurements of blood volume, we demonstrated repeatedly that a relevant amount of fluid disappears during major abdominal surgery. This is the result of our exact measurement of pre- and post-operative blood volumes, blood loss, urine output, and the amount of the infusion. Obviously, we need a positive fluid balance to maintain normal volemia. But how and where have these liters of fluid disappeared to? Via third space losses, or in fact simply by evaporation, which is termed perspiration insensibilis. This could already have happened pre-operatively, as additionally to the losses of urine, fluid constantly vaporizes during fasting. As a result, many clinicians still believe that even routine patients, which are not bleeding or treated with diuretics, have a preoperative fluid deficit caused by preoperative fasting. If this is correct, a positive perioperative fluid balance is nothing less than adequate. But is this now a myth or a fact? Fact is that by means of blood volume measurements, we demonstrate that routine patients have a highly normal preoperative blood and plasma volume even after 10 hours of fasting, and therefore no preoperative intravascular fluid deficit. Here you can compare preoperative blood volumes with normal values established by Pearson in non-fasting volunteers. Obviously, concerning routine patients, the preoperative volume deficit is nothing else than a myth, and its routine replacement as an EV bolus is inadequate. Preoperatively, there are two ways for insensible perspiration. The one by the skin and the other by expiration. The first question to answer is, what kind of fluid is lost? That's easy, it's vaporized water. More difficult is the question, how much fluid is vaporized preoperatively? In literature, various data is available. Some is gained indirectly by weighing the patient, but the better data is generated by direct measurement of the evaporated fluid by using a special humidity chamber. In Middle Europe, with a mainly moderate climate, the insensible perspiration amounts to about 1 liter per day. Of course, in countries like Africa, we will find a higher rate of perspiration. Insensible perspiration is not only dependent on air temperature and humidity, but it also correlates with the hydration state of the human being. The more you knock back at the bar, the more you will sweat out. Of course, I cannot answer the question whether this important principle has led to different drinking habits between Bavaria and the rest of the world. It's a dangerous joke here. Okay, I survived it. So, all in all, the average insensible perspiration is about 0.5 milliliter per kilogram of body weight per hour, which amounts to not more than approximately 300 milliliters after a fasting time of 8 hours. As demonstrated by our blood volume measurement, this small fluid deficit, even if we consider the urine output, usually does not lead to preoperative hypovolemia. To conclude, as there is no deficit, there is no need for volume replacement even after a fasting time for 8 hours. However, intraoperatively this could be different, as there is an additional very important way for evaporation, the operation wound. In order to clear this up, we have first to look at the insensible perspiration of the sleeping human. And of course, with the sleeping human, I mean this guy and not that one. It has been shown clearly that even during non-rebreathing ventilation, insensible perspiration is half of the rate of awake humans. Obviously, during general anesthesia, insensible fluid losses are reduced due to a reduced body temperature and mechanical ventilation. Data generated by waking patients and by exact balance indicated, however, that the insensible perspiration during surgery increases dramatically, leading to large fluid losses. But is this really true? I don't think so. Exact measurements of fluid evaporation, even over the maximally eventuated abdomen, showed that the total rate of insensible losses is at best doubled intraoperatively. This means that the intraoperative fluid evaporation can only amount to a maximum of 1 milliliter per kilogram of body weight per hour, and this fluid deficit should be replaced by crystallines. But all in all, it is less than 500 milliliters during a 6-hour surgery. As a result, the large fluid lost intraoperatively cannot have vaporized. So, where has it gone? One possible explanation is that this large amount of fluid left the intravascular space and is hidden in the so-called third space, which is probably an incorrect term for the extracellular space. Is this now correct? Indeed. It has already been demonstrated that during major abdominal surgery, there usually is a weight gain of 3 to 6 kilograms, which, please remember, is almost exactly the amount of fluid we were missing. How should we replace these fluid losses? As can be seen by the standard regimen of Brandstubedal, these fluid losses are commonly treated with crystallines. The reason for this is obvious. The extracellular space contains water and electrolytes, so the fluid loss into the third space has to be replaced with crystallines. But is this really correct? Not at all. It has been shown clearly that the interstitial space contains about 80 to 90% of the protein concentration of the intravascular space. Moreover, it has been demonstrated consistently that additionally to the protein loss via the surgical bleeding, there are large extra protein losses during major abdominal surgery. By means of the total intravascular protein mass, by measuring the total intravascular protein mass pre- and postoperatively, and the respective losses of protein via the surgical bleeding, we could demonstrate that there is a large intraoperative protein shift out of the vessel during abdominal surgery, major surgery. And this extra loss of protein is as nearly as high as the total protein loss via the surgical bleeding. A direct comparison between two groups, one receiving albumin, the other one hydroxyethyl starch, during major abdominal surgery showed that there is also an extra hydroxyethyl starch loss during surgery, an intraoperative hydroxyethyl starch shift, not via the kidney. Extra loss. As a result, there must be high losses of albumin and starches into the extracellular space during major abdominal surgery. Therefore, treating large insensible fluid losses only with crystallines is not adequate. Now, what is my intermittent cooking recipe for perioperative fluid therapy? As long as there is no evidence-based data which clearly demonstrate the opposite, we should give the patient what he needs. This means the application of the adequate fluid in an adequate amount, not being restrictive, This means a fluid supply less than the demand. And also very important, not being liberal. This means a supply beyond the demand. But how can we perform this? In order to answer this important question, we have to look upon the basic characteristics of infusion solutions. The main difference between the fluids we can use clinically are the colloidosmotic forces, which are highly different between crystalloids and colloids. There are also differences in electrolyte concentrations. If we just look on isotonic solutions, we can separate them in saline-based solutions and in the so-called balanced solutions. Firstly, I want to speak about the special characteristics of colloids. Albumin contains more negative than positive charges and has a phenomenal binding capacity. Today we know that beneath its transport properties for various substances, albumin has protective effects on the microcirculation, which are probably due to its anti-inflammatory effects. How much is now the volume effects of these EV fluid? Our group has performed double-label blood volume measurements to directly evaluate the volume effect of colloids. To measure blood volume, we work with two colors, green and red. Plasma volume was measured by the indocyanine green dilution technique, and red cell volume by labeling autologous red cells with fluorescein. And the sum of both volumes give the blood volume. In gynecological patients, we measured the blood volume after induction of anesthesia, before and after performing acute normal volemic hemodilution or volume loading with albumin. During acute normal volemic hemodilution, the infusion happens during an ongoing blood loss, whereas volume loading means the infusion without any blood loss. During normal volemic hemodilution, during a blood loss, 86% of the infused isoncotic albumin solution remained in the intravascular space. And despite a blood loss of 1.5 liters, normal volemia could be maintained by the infusion of the same amount of albumin. In a comparable setting, 250 milliliters of hyperoncotic albumin led to an increase in plasma volume due to a relevant reabsorption of interstitial fluid into the intravascular space. Therefore, the volume effect of albumin 20% was nearly 200%. However, in case of volume loading, which means the infusion without blood loss, more than 60% of the infused isoncotic albumin left the intravascular space, a major extravasation of the infused fluid and the infused macromolecules. As a result, the volume effect was below 40% in this situation. There were high volume effects if isoncotic albumin was infused in order to replace blood loss, and very low volume effects after infusion without blood loss. So why was this the case? In order to understand this phenomenon, we have to look on the vascular barrier again, and for those who could not listen to my first lecture, I will shortly repeat in this context the most important new insights concerning the vascular barrier. By using electron microscopic images, we could see that endothelial cells, which are connected by so-called tight junctions here, build up a confluent layer which acts as a competent barrier between interstitial and intravascular spaces. The function of this barrier was explained by Ernest Starling with a single barrier concept. He told us that in the vessel there's a high hydrostatic pressure driving fluid out, which is opposed by a colloid-osmotic pressure gradient between the intravascular and the interstitial space. By using a new fixation technique, we visualized a thick glycocalyx which is thicker than the endothelial cells here. And we know today that the vascular barrier is not a simple single barrier, it's a double barrier. The glycocalyx absorbs and condenses plasma proteins like albumin and forms the so-called endothelial surface layer with its own colloid-osmotic force, so that Starling's colloid-osmotic pressure gradient does not work between the intravascular and the extracellular space, the interstitial space, but just across the glycocalyx. It was already known that AMP plays a key role in blood volume regulation, and it's released by volume loading due to an increase in cardiac preload. And we could demonstrate that AMP can destroy the glycocalyx with a very important effect. These vessels here are healthy, and these were not healthy due to AMP, and these vessels were much more leaky for macromolecules and fluids. Moreover, in patients, we could demonstrate that the infusion, just the infusion of 1.5 liters of colloids without any blood loss during volume loading leads to a significant increase in AMP and a significant shedding of glycocalyx components, silicon-1 with tryptophan. Infusing the same colloids in the same amount during normal volume infusion resulted in no increase in AMP and no shedding of the glycocalyx. As a result, it's quite sure that the small volume effects during volume loading were caused by an alteration of the vascular barrier due to the release of AMP. Hydroxyethyl starch is eliminated by the kidneys. Tissue uptake happens especially after volume loading, a procedure which can lead to an increase in pruritus, which is a well-known side effect of starches. Additionally, hydroxyethyl starch can have impact on coagulation, and especially in case of sepsis, there are multiple large trials and meta-analyses which indicate a higher incidence of renal failure, even higher mortality rates in association with starches. Again, we measured the volume effect by using our blood volume measurements, and we could demonstrate high volume effects if hydroxyethyl starch was used as a replacement of blood loss, but only very small volume effects again if we infused it without any blood loss. In this situation, there was again an extravasation of about 60% of the infused fluid, and we measured it to the infused macromolecules. Obviously, an alteration of the glycocalyx reduces the volume effects of colloids independently if we use albumin or hydroxyethyl starch. The release of AMP causes this behavior of our colloids. A Cochrane analysis of the available data induced an academic storm that there is, as it demonstrated, that there is an increased risk of kidney failure and of dialysis due to the use of starches. The result of this analysis was a restricted use of this infusion solution in the presence. Crystalloids consists now only on water and electrolytes. They can be separated into balanced solutions or solutions having a high chloride content. All crystalloids which are saline-based carry a strong ion difference of 0 and produce a dose-dependent hyperchloremic acidosis. And this is also a problem for saline-based colloids. A very interesting question is now, how much are the volume effects of crystalloids? If we take a look at the data of large studies comparing saline with isooncotic colloids, we can indeed find an astonishing result. Fluid resuscitation with only crystalloids was equally effective than with colloids. But is this really correct? In the meanwhile famous SAFE study, the ratio between saline and albumin was only 1 to 1.7 in critically ill patients. The so-called Christmas study compared the infusion of volume starches versus saline in nearly 200 patients with severe sepsis, and the ratio of the infusion amount between the volume group and the crystalloid group was only 1 to 1.2 in order to reach hemodynamic stability. Can we really believe that the volume effects of crystalloids and colloids are almost equal? So we used Ringer's lactate as a volume replacement during an ongoing blood loss in a ratio of crystalloid supply versus blood loss of 3 to 1. the volume effects of crystalloids was below 20%. If there is a healthy vascular barrier, and if they are used for volume replacement, there's a large difference between the volume effects of isotonic crystalloids and iso-oncotic colloids. However, in critically ill patients, especially in patients with sepsis, a damage of the vascular barrier can occur and the volume effects of colloids decrease due to a leaky vascular barrier, so that the volume effects of crystalloids and colloids adjust each other. Intravenous fluids can prevent hypovolemia and a concomitant increase in mortality. However, if we give too much of a good thing, it's also not harmful. Too much of EV fluids increases mortality, probably also due to a breakdown of the vascular barrier, which is caused by release of AP. So at the end of my presentation, what can be my synopsis, my personal cooking recipe for maintaining normal volemia? For fluid losses, crystalloids are the best choice in a ratio of 1:1. For urine losses or perspiration insensitivities. If we want to treat volume losses, like blood losses, we have to give 5 times more crystalloids in relation to the volume losses in order to maintain normal volemia. There is no indication for colloids to treat fluid losses, and if you want to treat blood losses with iso-oncotic colloids, a ratio of 1:1 is adequate. If hyper-oncotic albumin is used, it is adequate to give half the amount. In my clinical practice, according to the final decision of the EMA concerning the use of hydroxyethyl starch, EMA, the European Controlling Institution of all pharmaceutical products, so I use crystalloids up to a blood loss of 1 liter in adult human beings, approximately up to 20% of the blood volume of the patient, blood loss 20%. As a basal therapy. If the blood loss increases further, I give colloids. And if there is no contraindication against hydroxyethyl starch, like renal disease or a critically ill patient who lives at the ICU, I give hydroxyethyl starch, but if there's a contraindication, I give albumin. However, there's a special case, namely severe inflammation like sepsis. In this circumstance, there's a breakdown of the vascular barrier. And in this situation, there's a large extravasation of fluids and macromolecules leading to low volume effects of colloids. And we will see, especially in this situation, the side effects of hydroxyethyl starch on the kidneys. So please let me summarize. Preoperative fasting does not lead to hypovolemia. This is really a myth. Also, the third space does not exist. However, there are large losses of fluids and macromolecules into the interstitial space during major surgery. I recommend preferring balanced infusion solutions. The glycocalyx is pivotal in maintaining the vascular barrier, and it determines the volume effects of infusion solutions. If the vascular barrier is healthy, the volume effects of colloids are much higher than that of crystalloids. If the vascular barrier is not intact, the volume effects of colloids are markedly reduced. So I assume that in critical illness, especially in sepsis, the breakdown of the vascular barrier is one reason for an increase in the side effects of artificial colloids. Albumin solutions seem to be a safe alternative in such situations. So finally, I hope that I could captivate you a little bit by my presentation, and that I did not destroy all of your dreams concerning myths. This would be a pity and not my intention. Thank you very much.